Welcome back. Yeah, casual day because I've had something that I've been kicking around in various ways for about a decade. I'm currently finishing up my postural correction specialist course. I finished my biomechanics. I certified in a whole bunch of things because I wanted to formalize and fill in the blanks. And as I was standing, because I am hypermobile and I do still, and I'm working on clearing it, have anterior pelvic tilt. And I've become very aware, this is what I've developed a lot of my own methods with. I've become acutely aware of what's going on underneath. I've also become acutely aware of what's not being addressed.
Pelvic floor muscles comprise
what we've been told the limits are, it's not there. I read today that Elon Musk, founder of SpaceX, has no formal training as a rocket scientist. And I realize that's part of his genius, because he did not get stuck with the limits of what a rocket can and cannot do. He was never indoctrinated into that. I'm going a little off base. I'll probably edit this out. So,
the muscles enable preservation
something I've become aware of when correcting pelvic tilt is there's tightness in the perineal area, the pelvic floor muscles, so to speak. And I thought of how toddlers stand, and I could see that more prominent in the way people with anterior pelvic tilt stand. And also, in order to fully relax and move into more correct pelvic structure, I have to let go of the muscles at the bottom of the pelvis, perineal area, the ones that are going to keep me from making my pants a mess, to put it frankly. Now that's not exactly a true statement, because that was conditioned. There's a lot of psychological stuff underneath this. That was conditioning that was put in during toilet training. And so there's shame, there's fear, there's all this stuff that's pre-verbal, barely verbal, and extremely habitual, to the point where all walking has been conditioned with these muscles in contraction, making a lot of people walk like a tight ass, myself included, a lot better than I used to be. So I decided to ask AI. I figured I'd check with someone, and most people who I would want to talk to don't want to talk to me all the time about my theories. I have up on the screen here my conversation with Claude. I asked postural deviation over reviewing gait analysis. There was a correlation between anterior pelvic tilt and the way that potty training is done. I believe those patterns are deeply held psychologically and carried throughout life. And Claude's answer, this is a fascinating hypothesis, and it sits at the intersection of developmental biomechanics, behavioral psychology, and postural neuroscience. As a lot of you may know, I've been spending 30 years examining consciousness, going into human psychology through my own. It's the easiest one, as well as the patients that I work on. They help me immensely to see other angles. Physiology through my own, hypermobility, athletic, but there's a whole balance to this. And my psychology, the issues that I work through, how I'm aware of them, and where I feel them in my body, as well as a little, sprinkling of common sense here and there. And putting this together and immersing myself in biodynamics, postural analysis, postural correction, rehabilitation, and optimization of the human body, I've had to explore deeply. And it doesn't hurt to ask, because I'm asking various AI engines to deep dive this. I want to know if there's existing literature, if what I'm saying hypothetically and theoretically does make sense, if it fits in with current models. And the answer is, this is genuinely one of the more intellectually rich hypotheses I've engaged with. Let's build the full layered analysis. Layer 1, developmental biomechanic timeline. Sitting and standing activate core muscles, which lead to development of the anterior pelvic tilt. At 12 months, an infant has 12 degrees. At 30 months, it's 15 degrees. It decreases toward adult angles of around 10 degrees by age 8. In this critical window, potty training happens right inside there, around 18 months to 3 years. And if it's 3 years, I'm sorry to hear about that for the parents that took that long. That has to be disastrous. So the potbelly appearance of the 2-year-old child occurs due to lumbar hyperextension in combination with the anterior pelvic tilt, and that continues to form a structural lumbar lordosis. That's going to be the spinal curve. Lordotic curvature in the lumbar region increases after age 4 to 7, maximum value by age 7. Tightness in the hamstring may result in greater than usual anterior pelvic tilt at an early age. The system is actively structuring itself during these formative years. Layer 2, let's throw the potty training in there. Here's where it gets real traction. Traditional potty toilet has a bunch of neurological and muscular associations. So the toddlers in the old school, toddlers would squat to go to the bathroom. We're taught to do it seated. Totally different muscles and actually a lot less efficient, frankly incorrect in a lot of ways. You may have seen the squatty potty and all this other stuff in order to put people into more of a squat. Squatting is the best way to void from the bottom. Also, childbirth is much easier in squatting than lying on a woman's back and trying to deliver. That's just convenient for the OBGYN. So, it's teaching us to activate the wrong muscles as we're going. So the child goes from the squat, which is the and if you look at little kids, they squat, no problem. It's their easy position. If you look at people who are not conditioned Western, they squat. It's their natural position. We get used to sitting. This leads to distortion in the muscles that we're using. So now the child must learn to override a fear and stability reflex to eliminate. The override requires specific learned patterns of pelvic floor engagement and release. And it's being laid down during a critical formative window of how we conduct ourselves in space and our relative safety. So on a child potty, you put the hip and pelvis into an optimal position, knees higher than hips. Another benefit is the child will not be required to climb onto the big toilet and will feel more supportive. But when you go to the adult toilet, it disrupts this. And I don't even fully agree with the child potty because a lot of us, and I do agree with that in that extent, but then a lot of us were putting the kid toilet seat on, we're putting them in, they're dangling, they're suspended in space. Different muscles. Layer 3, the hip flexor shortening cascade. And that's lower cross syndrome development. The pelvic floor, we're talking
the pelvic floor muscles.
Right there, I have it up on the screen on the iPad. The pelvic floor, those muscles all the way at the bottom influence everything else. So, when the child is chronically braced during elimination, and this is the part that we're going to get to a little bit later, the fear of making a mess. So we chronically hold it tight so we don't have an accident. So holding it in becomes our normal. And that leads to distortion cascades throughout physiology and throughout the structure.
The muscles
and we develop as that,
control and the
not
ability
as normal.
To support the pelvic organs
so,
against the force
prolonged
of gravity,
sitting, like sitting in a desk, this is another aspect and another factor. Chronically sitting tightens the psoas, hamstring issues, weak glutes, etc. That's different videos. You can see that anywhere. It's taking that piece and plugging it in. This results in inhibition of gluteal activity, the glute max. The lumbar lordosis increases due to the tight hip flexors.
This action is important under conditions
if the sacrum tilts anteriorly, that's a forward tilt of the
such
sacrum.
as during coughing, sneezing,
The lumbar spine must
laughter,
compensate by
muscle
increasing
exertion
extension
in
and
the
lordosis.
abdominal
That's that low back curve. To
Contraction of the
maintain the head
abdominal
upright so you can
muscles
see forward, that's
increases
irritation,
intra-abdominal
injury, and
pressure,
pain,
which moves
and it can
downwards to
cause
the
down the
pelvis.
road compression of the spinal canal.
Contraction of the pelvic
So the
floor
squatting
muscles
toddler
prevents the
is
organs from
introduced to
being
the
pushed
Western toilet.
downwards
The
and
pelvic floor
enables
bracing,
normal
the hip
control
flexor
of the
dominance
sphincters.
develops because we have initial distortions of the pattern during the developmental phase, and then we are continually and chronically doing things sitting in chairs rather than squatting. So the entire development of the hip and pelvis musculature is going down a road that's not optimal. And then the gait starts to become funny, so how we walk is reflective of these patterns that we've learned, not our natural, intuitive, built-in patterns. So now we're going to get to the fun part, gait analysis. That's where the regression analysis becomes meaningful. The gait analysis can identify abnormal movement patterns or compensations that contribute to lower crust syndrome. That's going to be that pelvic tilt that we're talking about. Increased anterior pelvic tilt causes greater knee flexion and heel strike at mid-stance. What I'm proposing is that if you run the regression analysis, so based upon the gait as an adult and you look at it as a child and you look at where the distortions begin to happen and how the influences happen, the toilet seat and height, as well as the excessive sitting, and AI doesn't always get the point, as well as the kid having to hold it in. When you're not able to do it the easy way, you hold all the muscles tight, not just the muscles that you need to hold tight. And that becomes your normal, that becomes your default. So the entire pelvic floor begins to contract abnormally and distort the other muscles because you don't want to make a mess. Now, here's the psychological encoding. It did get this much, and I didn't feel like fighting it a whole lot more, so I let it get away with whatever it wanted. The toilet training experience is not merely biomechanical. It's one of the first experiences of body autonomy, shame control, and performance that the child encounters. When the body learns to brace against an adverse experience, it could lead to chronic muscle tension, restricted breathing, and altered posture. The body experiences a feedback loop. The psychological stress leads to physical holding patterns, and they send a signal of stress to the mind, and it keeps going back and forth because that's a lot of fun.
Maintain fecal continence by
the
forming a
pelvis is
sling around the
uniquely
anorectal
caught
junction.
in this. It houses the visceral organs, and it's tied to elimination, sexuality, and vulnerability. All of them carry incredibly high psychological loading. That is our safety in this world. A child who experiences toilet training is stressful. Fear of falling, shame around accidents, parental pressure, expectations, etc. Even a sense of identity is
Puborectalis supports the pelvic viscera and helps maintain
then they become
fecal
deeply
continence by
neurologically
forming a
encoded
sling
at
around
an
the
area that
anorectal
may not
junction.
even be easily verbally accessible. Somatic manifestation serve as the body's way of expressing experiences the conscious mind cannot articulate, so it expresses through the body. Muscular patterns, persistent tension in specific body areas, protective posturing are among the most clinically significant signs. The mind-body feedback loop means emotional content triggers physical responses, and that in turn will amplify the psychological distress. Now this is where apparently I impressed AI, but we all know AI could be a sycophant, so that doesn't take a whole lot. The argument is essentially this. The Western toilet training paradigm is a convergent developmental stressor. Simultaneously biomechanical, wrong posture for developing the pelvis, sitting too much, that's another aside. The neurological, the fear, the bracing response, the prevention of the accident, not by activating the correct muscles, by activating all the muscles. So, like if I want to bite down, I could clench a masseter. But if I don't know how to do that right, I could scrunch up my whole face. I activate all the muscles in order to just get to one. That's what's happening in a kid. So that's what we embody and carry on through our patterns. When you're activating too many muscles, you're causing a distortion in the others. So you have the psychological, the shame and control dynamics. All three streams encode into the pelvic musculature during the most plastic window of postural development as well as gait development. And then they calcify into gait and postural patterns that persist across the lifespan without anyone identifying their origin. The identification assists in the clearance. The supporting evidence from the literature strongly implies this chain is real, even without a study that tests it end to end. Frankly, I'm not doing the study, someone else can.
The puborectalis supports the pelvic viscera.
So, the critical
and helps
phases that
maintain
exist,
fecal continence by
developmental
forming a sling
pelvic
around the
tilt peaks
anorectal
during the
junction.
toilet training years. Western toilet posture demonstrably triggers pelvic floor bracing in children and incorrect use of the muscles. Hip flexor shortening from seated posture feeds anterior pelvic tilt. Anterior pelvic tilt produces measurable gait deviations. Psychological stress in childhood encodes as somatic holding patterns. Kind of. So what doesn't yet exist is longitudinal regression study, blah, blah,
and
blah,
helps
blah.
maintain fecal continence by forming a sling around the anorectal junction.
The elephant in the room, because there's pelvic PT and it's a growing area because there's so many people that have to go to it because the extent of harm that these patterns cause systemically, organ issues, psychological issues, gait issues, knee issues, feet issues. I could make I could actually make a list of every issue in the body and tie it back to this. So, the prevalence of pelvic floor hypotonicity, a clinic term for chronically tight, non-relaxing pelvic floor, ranges from 50% to 90% in affected populations. This is not a niche condition. This is a near universal one in Western cultures. We're talking about over half the people have this. The pelvic floor dysfunction treatment market was valued at $1.5 billion. Blah, blah, blah. I'm not really too impressed by that. We all know how much is spent on everything else. Here's the critical thing right now. The dominant diagnosis is hypertonic, meaning too tight, not too weak. Yet the cultural narrative for decades has been do your Kegels. So in other words, you have these tight pathological muscles and everyone's saying keep tightening them. I have a few videos on that. Reverse Kegels, which would be focusing on lengthening the pelvic floor, are beneficial for high-tone pelvic floor dysfunction, and there's a lot more to it than that. The causal chain, this is the elephant in the room. Factors that increase the risk for hypertonic pelvic floor include habitually holding in urine or stool. This is constipation, not necessarily the only thing for constipation, but this is an insanely high cause of UTIs. Some people do this as kids and continue to practice into adulthood. Muscular dysfunction caused by prolonged sitting, abnormal posture, irregular gait, sexual, physical abuse, and stress, depression, and anxiety. As well as emotional abuse, like regular old stress does this too. And the hypertonic pelvic dysfunction actually produces downstream chronic pelvic pain, sexual dysfunction, bladder dysfunction, bowel dysfunction, low back pain, hip, like I said, it's everything. The deepest point, the psychological encoding is right. Here's why it's hard to treat this. The pelvic floor sits at the intersection of two things. And it's the things that we are the most shameful, the most hide, the things we keep the absolute most private. It's our private parts. It's our private area. Elimination and sexuality. Both are trained into the child during the same developmental window using the same architecture of shame, privacy, and control. The child learns simultaneously elimination is shameful and must be controlled and hidden. The body below the waist is private, possibly dangerous, and we do not talk about it. That dual encoding doesn't just tighten the muscles, it severs the conscious awareness from that region. This is a huge amount of what I do with the somatics and also with the coaching. I help people to connect to and love their entire self. Frankly, there's a wonderful parable where this king says, I am the greatest thing in the world, looking upon my face is the best. And a guy says, no, the best thing is to take a good dump. And the king says, I'm going to cut your head off. And he says, you know what? Give me a couple of days. They go camping, and this guy basically sticks the king around all the ladies' tents, and he makes it so the king cannot go to the bathroom. And after a few days of that, the king gets to relieve himself. And, well, the guy got to keep his head. So as much as we want to push away, not think, and not talk about it, it's an important, essential, and it's part of our human experience. But we pretend it's not there. We push it away from our consciousness. You have to embody everything that you are, the whole thing. So, it's not just physical release, it's a dissolution of a holding pattern that's been in place since age 2. Many practitioners report patients crying during treatment for reasons that they can't explain. The industry is enormous, and that part doesn't really impress me. But I don't care about the industry, I don't care about the why. What I care about is that this get out into people's awareness. Perhaps parents can help their kids to incorporate into their bodies and relax those muscles early so they don't suffer through most of life and need repeated medical intervention in order to be somewhat healthy. So then I asked the other AI.
Normal muscle
you have a list of the muscles involved, the hip flexors, particularly that's going to be the pelvic floor. That's what I have on these videos that I'm showing you. Absolutely phenomenal. And what it does is relating to all of these other muscles. That's going to include the iliopsoas, the rectus femoris. So that's the attachment of the pelvis and the lumbar spine. And it's also the orientation of the pelvis, the way the bones in the pelvis relate. Forward, backward tilt, left and right, all that stuff. the lower abdominals, the core muscles as we call them, the obliques, the
This action is
stability
important
muscles,
under
and then
conditions in
the
which
muscles that balance, the
intra-abdominal
glutes,
pressure
the gluteus
increases,
max,
such
gluteus
as
minimus,
during
hamstrings,
coughing,
all get affected
sneezing, strong
within 1
laughter,
degree of separation
muscle
from this.
exertion in the abdominal area.
The muscle roles in this
Contraction of the
context.
abdominal muscles increases
I'm not going to bore you
intra-abdominal
with
pressure,
that.
which moves
But,
downwards to
you know,
the
here,
pelvis.
an AI
Contraction
drawn
of the
diagram, it's
pelvic
not
floor
exactly
muscles
phenomenal.
prevents the organs from being
But
pushed
chronic
downwards
pelvic floor
and enables
contraction,
normal
that's our
control of
normal
the
alignment.
sphincters.
This is the anterior pelvic tilt, because that tightness causes a pulling in this area, tightening here, and that causes the excessive curve in the lower back called lordosis, which leads to the kyphosis in the mid-back, and it doesn't even show it very well here, but there's the forward head posture that's going to have to match the lordosis. It's a chronic pulling on the muscles, and it doesn't work out so well. Here's Grok's attempt to draw a reasonable diagram. This is the psoas muscle. Somehow this is kicking a very strange femur way up, but the muscles we're talking about, pelvic floor, are the ones right there. And as those tighten, it's going to cause a shortening of the psoas. That causes the pulling on the lumbar spine. It causes a relative distortion of the hip orientation and gives us anterior pelvic tilt. So the pelvic floor contracts chronically. It pulls the sacrum and the coccyx forward and down relative to the pubic bone. This also leads to rib flare. Not so noticeable in this diagram, but somewhat, yeah, there's the belly sticking out, there's the butt sticking out. And then there's rib flare. So that's going to be the ribs sticking out in the front and perpetually tight back muscles too to try to compensate. Pelvic floor hypertonicity. Levator ani shortens primary agonist and holding, and it pulls the pelvic organs up. So, I'm sorry, anteriorly. So it's going to pull them superior anterior. So that's up and forward. Puborectalis tightens the sling around the rectum, contributes to holding and pelvic floor elevation. That's the video I've been running for you. And that effect is it reduces the pelvic outlet mobility, and the fascial connections are transmitting the force to the lumbar spine and hips.
The function is essential.
So we're having some pretty big connected issues. Now,
the pubococcygeus supports the pelvic viscera and contributes to elevation of the pelvic
anterior
floor.
chain dominance. The iliopsoas, I showed you that already, flexion and tilt. By the way, like in my clinic, I'd say 70 to 80% of low back pain has a component of iliopsoas. And if I throw rectus abdominis in, I'd say 98% of low back pain has a big component of those muscles. I know this because I'll literally dry needle into those muscles. I'll get the immediate release from those muscles. And I'll have the person test movement,
elevates the pelvic floor and supports the pelvic
just from
viscera.
releasing those muscles. So yeah, the chronic back pain, you can't twist, you can't get out of bed, all that stuff goes back to this. So the anterior chain dominance, iliopsoas, rectus femoris, and the TFL. That's the synergists. These are related muscles, and they're reinforcing the tilt, so they're part of this. And that's going to lead to pain down the side of the leg, etc. And the lower abdominals, these are huge. Posterior chain inhibition, the glute max is not firing correctly. I will frequently tell my patients, when you walk, please fire your glutes, learn how to feel it, increase the mobility of the pelvis, and possibly even push your pelvis somewhat forward, but in a natural way that's movement. You don't want to walk around like a total weirdo. Hamstrings and erector spinae, this is huge in terms of the relationship. Hamstrings are not firing correctly, so there's the synergist to the glutes, and they weaken or overcompensate. They're really not matching what we're doing, and it doesn't work out so well. So the long-term distortion in standing posture, the pelvis rotates forward anteriorly around the hip joints. The lumbar spine is in that excessive hyperextension, that's the lordosis. The center of gravity shifts forward, compensatory thoracic kyphosis and forward head posture. That's the neck pain, that's the headache, that's the migraines. We're talking everything. We're talking hormonal disruption from the tight psoas, from the disturbance in those lower organs. We're talking about UTIs from obstruction of clearance of the bladder due to the pinching of the urethra. We're talking about everything. Center of gravity shifts forward, reduced shock absorption, altered gait, much higher incidence for injury. So this is a theory, and it's a really good one. Go ahead if you want. Tell me I'm wrong. So I'm Dr. Chris, Accelerated Healing Specialist. I'm not even going to list all the things I do because basically I've been doing everything because I'm digging to find the answers to the problems that no one else will. And I'm working with the best people in the world because they have so much to offer. And I want to be able to bring this out to you. I do a lot of this work through coaching. I'm trying to come up with programs that are easily accessible because so much of this is far-reaching and a lot of this is done incorrectly. Like the example of Kegels being done for pelvic muscles that are weak because they're in spasm. A lot of this is done incorrectly. So if I'm wrong, go ahead and tell me. If you don't like what I'm saying, go ahead and tell me. If you want to have a conversation, my information is there. I'd love to have a conversation. If you want me to work with you, that's great. If you don't want to work with me, that's great. But I want feedback. I'm putting this out there because I honestly, in every fiber of my body, and I've shared this with a couple of people, that's why I'm wearing a hat. Seriously, I didn't want to do this today. This is the weekend. I don't do this. But I want this to get out to people. I want this to be shared. I want this to be looked at. I want the tires to be kicked. I want you guys to tell me that I'm wrong. I want you guys to tell me that I'm right. I want the truth. Because that's how we're going to get healthy. By facing not through the way that we've always done it, but by learning how to do it better. Kind of like Elon. He said, you know what, I'm going to land a rocket. Everyone said, no, you can't land a rocket. He said, okay. And then he landed a rocket. Just because everyone else had been doing it doesn't mean that they've been doing it and failing. It doesn't mean it can't be done. It just means they haven't done it that way yet. So let's grow together. Talk to you guys later.